My name is Dr. Shoukat, consultant nephrologist. Today we will continue our last segment of scenarios. This is a part two, and overall the last segment of the acid-base disorder discussions. This one, the sixth presentation. So before I will go to the mixed disorder of the scenarios, let me recapitulate what we have learned about the delta delta because it's very important to learn. If you look up at this picture, the anions, the calculation of the anions is represented as the chloride and bicarbonate, little bit contribution by the anions, and mainly the albumin contributes more in the anions and little bit contributed by the phosphate, sulfate and other anions. What happens when there is a metabolic disorder? The anions get accumulated, and you can see in this picture if it's accumulated up to this level means the difference of the anions, accumulated anions is, say for example, is 12, then this makes the figures 24, and that rest 12 is at the cost of declining 12 of the bicarbonate. In the perspective of the simple acid-base disorder or single acid-base disorder. So if you take the same thing in this example, then we can say if there's high anion gap metabolic acidosis and that anion gap is increased by the 12 and becomes the 22, and that we have discussed that is at the cost of declining of the bicarb in terms in the perspective of the single disorder, then this makes 12 by 12 and it is 1 by 1, and ultimately is a 1. The typical ratio of delta delta is 1 is to 1 or 1 if we are dealing with a single high anion gap metabolic acidosis. But if it is deranged, means see, if we encounter high anion gap metabolic acidosis, then the ratio is typically between 1 to 2. We have said the typical is 1, but the range is to 1 towards the 2, but the nearer the 2 or more than 2 signify some pre-existing retention of the PCO2 or the concurrent metabolic alkalosis. There are two possibilities when we encounter the delta delta more than 2 or then sometimes the nearer the 2, and in case of the delta delta is less than 1 or near 1 or less than 1, then typically there's concurrent normal anion gap metabolic acidosis. Now we are going to the scenarios, then we'll learn more. See this scenario, the diabetic ketoacidosis, the pH is acidic and PCO2 not more than 40. So with these two steps, we come to know that acidosis is related with the metabolic component. And here the bicarbonate 5 means there's deficit of 19. So definitely this is the high anion gap. The anion gap is in this case 18, and you can set expected PCO2. We take the expected PCO2 with by using the winter formula, or sometime we use typically I also use often with this equation, 1 drop of the bicarbonate causes drop of PCO2 1.2 times. Now in that case the 19 drop of the bicarbonate will make 1.2 into 19 uh, something around 22.8, and that would cause the declining of the PCO2 from 40 up to the level of the 17. So plus minus 2 we give the room, and the patient's PCO2 is 16, so this is very much near to that 17. If I decline this, deduct this from the 40, we get the expected PCO2 and very much near to that. So this is adequate compensation of PCO2 with the high anion gap metabolic acidosis. Now delta delta, we know the change in the anion gap by change in the bicarbonate is less than 1. And when we encounter the less than 1 of the delta, then it becomes the high anion gap metabolic acidosis along with the normal anion gap metabolic acidosis. Hope this makes you clear as I can explain further in the subsequent scenarios. Now, in this scenario, 50-year-old insulin-dependent diabetic woman brought emergency semi-comatose condition, several days illness, and medication history is the thiazide and the digoxin. Now we start learn from the background. I mean the scenario in this lady. What might be expected? Now the use of diuretic congestive heart failure. In congestive heart failure, we often get the respiratory alkalosis due to wash of the PCO2, and with the use of diuretic, we get the contraction alkalosis. So in this lady on semi-comatose condition, the sugars is sky high, so that is actually the decay case as ketone in the urine as well. So pH is 7.41. PCO 32 and BACA 19. It's not that much deranged, but these being in opposite direction, then the PCO becomes the normal. But is it adequately in opposite direction? Let's see. The anion gap is 34, and the compensation is almost adequate by using the Winter formula. You can calculate, and the delta anion gap is 22. Means the change in anion gap is 22 as we take the cutoff value of 12. Some people take the cutoff value of 10, sometimes we take, but here we are taking 12 as cutoff. So 22 delta gap, and the delta bicarbonate is 5, as there's 19 bicarbonate deficit. Falling of the bicarbonate is just 5. So the what will be the delta would be of obviously more than 2, and this makes the diagnosis of high anion gap metabolic acidosis with metabolic alkalosis. Now take another example, the alcoholic liver disease having a lot of vomiting and the lactic acidosis. We know lactic acidosis causes the acidic pH, and vomiting may cause the contraction alkalosis again. So these are the background, but if you see over here, the pH is a little bit acidic with the PCO2 31. So with these two steps, we are sure that it's not predominantly respiratory acidosis, as the PCO2 is not more than 40. Now, bicarb is 16, suggestive of the metabolic acidosis, and at the level of 16, we can calculate the anion gap, which is 27, and what will be the expected PCO2 and the delta. So delta is more than 2 by calculating as a delta anion, as the cutoff stoil and the rest or the change in the delta anion would be how much? See over here, the 7 15 and the 7 the delta bicarbonate is more than 2. So diagnosis the high anion gap metabolic acidosis with the metabolic alkalosis. Diabetic ketoacidosis with lactic acidosis after bicarbonate therapy. That's very interesting scenario where we find this almost normal values, but the patient is very sick. And whenever you encounter such normal values with the patient very sick, then there must be some disorder, more than 2 disorder. And here you can see what is the anion gap. Anion gap is 24, means the change in anion gap is 12, and there's no change of bicarb. So that makes more than 2, and the diagnosis is high anion gap metabolic acidosis with the metabolic alkalosis. So see, these two disorder with the normal pH because of the bicarbonate therapy. And in this scenario, 69-year patient, cardiac arrest following operation, and resuscitation CPR was done, and patient was ventilated. And within 5 minutes, 5 minutes of CPR, blood gas is typically this. Very much acidic pH with PCO2 82, and this is a PO2 bicarb 14, lactate 12, and anion gap is 24. So the diagnosis obviously high anion gap metabolic acidosis, and that is the metabolic component contributed by lactate generation because of the cardiac arrest. And the respiratory acidosis, why do we say respiratory acidosis? As the PCO2 is retained a lot. So respiratory acidosis, metabolic acidosis, this is a mixed disorder. Don't rely blood gas immediately for CPR. Recheck later on, because when there's cardiac arrest and CPR is done and patient is reversed, then we should recheck it after the circulation established, so that the accumulated PCO2 and the lactate in the body should be washed out, and then this will represent truly what is happening inside the body, and we should not take decision on this immediately post CPR blood gases. That is the learning point in that. Now, patient hepatic, renal, and pulmonary failure, three are gone involved, and this is the blood gases. And see what is the anion gap. Anion gap is 17. What is the diagnosis? High anion gap metabolic acidosis with respiratory acidosis. So, see, why do we say that? Again, the anion gap is obviously more, and along with that, the respiratory acidosis, you can see the blood pH 7.18, and PCO2 is also more than 40, but little bit more than 40. It's not predominant respiratory acidosis, as bicarbonate significantly dropped. So the predominant component would be the metabolic acidosis, and as the in simple disorder, this must have been declined, but it has not declined. So there is a component of the respiratory acidosis as well. Uh, Now go to another scenario in the background of COPD and diuretic. With this information, we can expect in COPD patient they might be retaining the PCO2, and using the diuretic might be suffering from the contraction alkalosis. The pH 7.4 for little bit alkalotic with the PCO2 55. That is the respiratory acidosis signify the respiratory acidosis, but pH little bit alkalotic. You should see the bicarbonate with 36, almost 12 more than the normal cutoff is 24. So the predominant is the metabolic alkalosis, but is the rest PCO2 is up to mark? Think expected disorder in our scenario. The pH is in the normal range but inclined towards alkalosis. PCO2 is acidic, so C bicarbonate, which is alkalotic, so expected PCO2 47. But this patient is having a 55, means carbon dioxide is also retained. So this is suggestive of the metabolic alkalosis with respiratory acidosis. Another scenario is congestive heart failure and diuretic. On diuretic, again, with this information, we expect somebody may lose the PCO2 and become respiratory alkalotic. Uh, uh, this is the prior understanding, prior to see this blood gases I'm just making. In the actual scenario, you may encounter the same thing. You may not, because this is depending on the timing of the presentation. Some people wash up PCO2 and present very late, so they start returning at the time. Uh, and this patient is also on diuretic, and that causes the contraction alkalosis. The pH is alkalotic, the PCO2 is 40. It's not suggestive of the predominant respiratory alkalosis. So bicarbonate 38. Obviously, this is the metabolic alkalosis, but the PCO2 has not increased up to that level, means there is a washout of PCO2 as well. So what will be the expected abnormality? We can see there is a 14 digit rise. The 14 rise of PCO2 should raise PCO2, uh, and the should raise PCO2 up to the 10, and the diagnosis becomes a metabolic plus respiratory alkalosis. So hope this makes you understanding clear. Now in this scenario, COPD patient with hypotension and pH is acidic, PCO2 is very high, and with that PCO2, is the bicarbonates up to that high or not? See, pH acidic PCO2 favoring 40 rise of PCO2 from baseline should increase bicarb how much? So the diagnosis is respiratory acidosis with metabolic acidosis with raised anion gap. In this scenario, 41 male presented emergency with these labs. See the sodium 140, potassium 4, and chloride 110. The pH is acidic, the PCO2 36, and the bicarb is X. Predominant is the metabolic acidosis, and what about the expected PCO2 is around 21, anion gap 22 is high anion gap, and the diagnosis would be the high anion gap metabolic acidosis with the respiratory acidosis. Then we should also see the delta delta. Are there only two disorder? No, we should see the delta delta, and it is less than 1. How did it come to less than 1? You can see the delta 9 is 12 and the delta bicarb is 16. So it's making less than 1. So this is third disorder along with the high anion gap metabolic high anion gap plus normal anion gap metabolic acidosis with respiratory acidosis. Another scenario, 75-year heavy smoker, severe airway disease, presentations confusion, fever, and significant respiratory distress, and several weeks of the unwellness. So what abnormality do you expect in this scenario? pH is acidic with the predominant respiratory component, and bicarb is a little bit more than the cutoff. So this is respiratory acidosis with metabolic acidosis. That is obviously because that is the component of bicarbonate is not that much less in comparison to this much. So the respiratory acidosis along with the metabolic acidosis is there. The 70 years male with a severe congestive heart failure and the several weeks of unwellness, vomiting is there, no medication, and the admitting biochemistry is this. pH 7.5, alkalotic with PCO2 washouts. So respiratory alkalosis is there. What about the bicarbonate and the anion gap and the delta delta? Anion gap is raised and delta delta is obviously more than 2. The delta anion by delta bicarbonate. So here the bicarbonate is 20, means not that much lower, something causing accumulation of bicarbonate. As in this scenario, I take you back in this scenario, the clue of vomiting is there, which might be causing the rest bicarbonate. So the diagnosis would be respiratory alkalosis with high anion gap metabolic acidosis and plus metabolic alkalosis. There are three disorders found in this scenario. So, okay, I end over here. Thank you very much for listening. And if it is productive for you, then please subscribe so that I can share another video. Thank you very much. अपना ख्याल रखिएगा. Assalamualaikum.